We've got our 4 speakers lined up. We're going to have a session today on GPDPR. I suspect it will be quite wide-ranging because there's quite a lot of history around this topic anyway. I've myself and Paul stood up this collaboration, we'll call it, gang, a year ago or so during COVID, with a sort of an open bias towards the linking and sharing of data. And I historically worked at Dr. Foster and would have been around things like care.data and other things in the past, but I'm really interested to just have a more balanced discussion about some of this. So interesting that some of our speakers say they're enjoying the opportunity to come into a kind of an open data environment. But I think for myself and for others, I think we have been in that camp, but don't coordinate and liaise enough with people who have differing views from ours, not better or worse, just different. So I'm really interested to kind of have a good discussion here, which we'll write up and we'll share all the material, and we're recording it, so it'll be there for other people to see and for you to share as well. This issue's been around for a while for those who know about it. So there's been issues like care.data in the past, and that was not launched well. A good aspiration, and you see that in the NHS Digital's website now with their nice little videos about the data's not going to go out to marketing companies or insurance companies. It's going to be used to plan and research in a similar but different way to the way that the census is collected. But these things often become high profile very quickly. You will have been aware, if not of this, of things like Cambridge Analytica hitting the press. You might be aware of the work that the Royal Free did a few years ago, trying to develop an algorithm with Google DeepMind around acute kidney injury. A lot of people would say the aspirations were altruistic, but you've got to do it in a very careful way that aligns with the law, but also aligns with people's ethics and morals. On this group, we've done some work around domestic abuse, which is very sensitive. So we linked anonymously data from the police and from the NHS in a spirit of trying to attempt to find families that might be at risk of domestic abuse. But if you just said to someone, we're going to link some data from the police and some data from the NHS and sort of fish around and see what we can find, and potentially find benefit fraud or illegal immigrants, all sorts of things, you quickly get to a point where people are not comfortable with data. So you have to be very clear and very proportionate how you do these things. It's difficult. There's quite a lot of research out there that shows that most people are broadly in favour of linking their data for research purposes. Paul and I kind of semi-famously convened this, having come back from a skiing holiday with a group of people who all caught COVID and were very open about sharing symptom data on a closed WhatsApp group between each other. So there's a kind of spirit of people sharing data for greater good, but it has to be done really carefully. We're really lucky we've got 4 expert speakers with us to give us kind of different perspectives on this. Marcus, I'm going to come to you first, if I may. Marcus is the chair of the RCGP Health Informatics group. He's actually a freelance software developer and a Locum GP, so I'm assuming you don't sleep at all. But very interested in your perspectives on this, Marcus, as our first speaker.
Thanks. So this is thank you very much for inviting me. It's really nice to speak to the open data community about this, because I think it's a really interesting area, and I think lots of good comes from data. So we're keen to see this kind of stuff happen, and we're also keen to make sure that it doesn't kind of damage anything in doing so. So I guess when I say we, I mean the profession, the GPs that have put this data in, because when you see the patient, you see a patient, and the patient will tell you information that they would not normally tell anybody else. So we're privileged as GPs and as medical professionals, nurses, all kinds of professions within the NHS. People tell us stuff that they would absolutely never tell anybody else. And so that comes with special responsibilities. We've recorded that data, and remember that back in the good old days, we used to record that on little pieces of Lloyd George envelope card, which were absolutely not something you could aggregate into big data. But over time, we've come to the point where we have got our data in big hosted systems where it's all together in one big place, and that starts to make it much more accessible for using it for good purposes like research and planning. So the purpose of this program is GP data for planning and research. It's a slightly, it's a shame that they chose that acronym because it's so near to GDPR, which is the, an entirely different kettle of fish, EU legislation, which is now in UK law about data as well. But this program is about gathering data and making it usable for researchers and for planning of the NHS and planning of services. Crucial to point out, it's not for any form of direct care. So some of the discussion around this sort of conflates the issue of having to repeat yourself when you go to hospital, for example, and GP data for planning and research. And it's important to really separate those two things. Direct care, data sharing for direct care is something that is usually done with essentially the implied consent of the patient, because the patient usually does want their data to be available to the hospital, available in the GP surgery, available to the podiatrist and to their physio. And that's a much easier set of arguments. This is all about research and planning, nothing to do with direct care. And so I'm just going to talk about some of the sort of open data relevance for a couple of minutes, and then I'm going to stop. So in terms of what can result from this program that is usable by the open data community, well, really anything that's open has to be anonymized and aggregated data, because anything that isn't anonymized or is not aggregated is actually still re-identifiable. And that sort of forms some of our concerns about this data, because any sufficiently rich data set like this, so in the case of your GP record, that's your whole life rendered into what we call SNOMED codes, which are just little terminology codes that mean certain medical things. And if you've got enough of that data, you could probably re-identify somebody even in a very large data set like 55 million people, just by knowing things that happen to them on certain days. So if you know that a lady had a baby on a particular day because she put it on her Facebook feed, and then you know her previous child was also born on a specific day from her Facebook feed, that's probably enough to identify a person uniquely in 55 million people, because how many women have had a baby especially if you know the location, if you know the sex of the baby, the location of the baby, and the dates, you've probably got them. So that's why this data is so sensitive to us, because the nature of the way it was given to us was for the patient's direct care. Now, we are very on board with the idea of secondarily gaining some benefit from that by using it for other things, but we mustn't forget where it came from and why it's with us. So open data that could come from this would have to be the top level sort of aggregated anonymized data. But that said, there's an incredible wealth of knowledge and benefit to be gained from that data. So I'll stop there and move on to the next speaker. And then I'm happy to take any questions at any stage.
Thank you, Marcus. We tend to get quite active chats on these as well, which we will write up afterwards. So feel free to, if you've got questions in there, jump in, but we'll also, between me and Paul, we'll bring some of them out anyway. Tina, we'll come to you, if we may, for a kind of different perspective. Tina's kind of job title is on our website, so I'll let you go straight in. People can kind of have a look.
Sure. Can everyone hear me?
Yeah, loud and clear.
Excellent. And I have a few slides, partly just to kind of focus myself, because I have a tendency to become very sort of effusive and get carried away with things. So it will hopefully focus me a little bit. So can I have the slide, my first slide? I think your team is going to be
Ross, if you could.
Is it up there?
Hopefully.
I'll just start talking. So, I mean, essentially, the focus of my talk is building trust to deliver the promise of the recent health and care data strategy. How do we engage the public? So, I wear a few hats, and I don't know if the slides are up on the screen yet. Are they? No, I don't see them. Okay, I'll just talk without slides then. So I wear a few hats. I'm a social entrepreneur more than anything. Essentially, what I do is work with a number of organizations, focus very much on actually the system change in health that I'm really, really interested in, because at the moment we do have a sickness model. And so I think all the issues around public trust in the GPDPR debate are actually more or less identical with some of the issues that we're exploring at the moment with what we're calling the Open Life Data Framework, which came out of some work that I'm doing via the All-Party Parliamentary Group for Longevity. And essentially what I'd like to do is open up a discussion about seeing the whole debate as part of a bigger debate on citizen engagement around data and in this more sort of preventative health paradigm. So that's sort of where I'm going to be heading with this. So next slide. Just a little bit of a word on on the open, so if we can go to the next slide, a little bit of word on the work that we're doing wearing my All-Party Parliamentary Group for hat for longevity is we published a report last year called Health of the Nation. We came out with a follow-up report called Leveling Up Health, which was published a couple of months ago that had a lot of support, from our then Secretary of State, but also Chris Whitty. And essentially what came out of that was an endorsement around a couple of the initiatives that we're very, very focused on at the moment, which is on the one hand, Business for Health, which you'll see in that Lancet article at the back, Our Unhealthy Nation. It's very much focused on the role of business, working with public sector on how we can do more to improve health post-COVID. And then the piece of work that I'm going to focus on in my talk now is the Open Life Data Framework. And just hearing Marcus speak, I think one of the things that we're really sort of, I guess, facing, and I think is a big issue, is communicating to the public and indeed, ourselves as a community. What do we mean by open data? Because I think there are lots of different definitions and ideas around that. And I think it just is one of the examples about the communication that we need to really get right when we're speaking about all these topics. So the work that we're doing with the Business for Health venture connects up with the Open Life Data work that we're doing. In fact, we're developing a business index to measure the business contribution to health. And the reason why I mention that is because we're really looking at the value of private sector data sets in this wider data ecosystem. So if we go on to the next slide. And the reason that we're doing that is because many of you will know, and especially coming out of COVID, we know that those who are most affected by COVID are those, where the wider determinants of health are really at the root cause of, it's the root cause of health inequities, etc. And you can see on that slide, it's an old IBM slide, but it really sort of points a finger to the fact that in terms of the determinants of health, most of that actually sits outside the health and care system in terms of our environment, housing, poverty, things like that. And even, things like air pollution, these are all sort of factors that are involved in that. So what we're doing with the Open Life Data Framework, which in the previous slide you saw was, we got a piece in the Lancet that focused on what we're trying to achieve with that. What we're trying to say there is that, listen, we need a framework that will really open up our view on what data is important to understand and measure, in terms of our health, but how we can help researchers, policymakers, and entrepreneurs work out what data outside the healthcare system, that the so-called healthy data that we've got on that slide, including the non-health data for health. So this is data like, mobility, consumer data, environmental data, financial data, and combining that with this, what we call the SIT data, the data that exists in our health and care system, can provide the most insight. So if we go on to the next slide, so we talk a little bit about this wider concept, and I'm giving this sort of helicopter view of why we see this public debate of citizen data sharing is so crucial to this, because there's this wider view of health that we're really trying to, I guess, sort of unearth and get people to really understand how this so-called exposome of all the environmental factors in our health, such as diet, housing, air quality, all these sorts of things, can help advance our goal within in the context of the APPG goal, which is 5 extra years of healthy life expectancy while minimizing health inequalities. How we can do that. And so within the Open Life Data Framework that I mentioned, we're working with people like Gavin Starks, former ODI CEO, who who was one of the co-architects of open banking. And so really what open banking did was to open up the whole innovation platform, the whole, and wresting control of data away from the banks, giving it, and this was driven by GDPR and PDS2 regulation, giving data portability back to consumers, et cetera, et cetera. So we're taking some of those principles into how we're thinking about this data ecosystem. So we've now chosen 3 really interesting use cases that will help us design this enabling data infrastructure and governance mechanisms to harness data sets in both public and private sectors across the life course, looking at solutions and use cases across personal, population, and pandemic resilience. And we're linking that to some of the priorities that we set out in our Leveling Up Health report. Really what are the big areas like obesity, healthy children, food is a big area, clean air and smoking are some of the priorities that we're looking at. So the next slide, from cells to cities, we're taking quite a helicopter view on all this. And the 3 use cases that we're looking at to really unpick some of the barriers and the challenges are, linked to obesity, food, and healthy children, for example, is the Digital Red Book for Life, where we're looking specifically at weight management. We've also are looking at a data exchange, which is looking at supermarket basket data and epigenetic profiling to identify those who are, who are eating, who are the most vulnerable populations and those who are eating the most unhealthy food, and nudge strategies, etc. And the other use case is looking at civic data cooperatives. So this is looking at, and this has been championed by Ian Buchan up in Liverpool, some of you may know, to develop local public health intelligence and learning systems that can be connected up on a grid. So really looking at sort of local sort of driven approaches, harnessing civic action within a local diameter of trust. So these are all, and of course, all this work and what keeps on coming up is, what we can do as citizens, what we can do with all stakeholders in society, but also the role of government in all this to enable and to ensure health is seen as a priority for example, in health and all policies, so that across all departments, recognizing also business is also a key role to play, and how we can link up health and wealth. And of course, in the Leveling Up agenda is really, really important. So the Open Life data work is connecting up with the work that we're doing by this business index to measure business contribution to health. In terms of workforce health, we know that depression, musculoskeletal conditions, for example, are huge factors. And of course, the business community can do far more. They can also have a key role in good work and local jobs. So that all connects up in this much broader view of health. But fundamentally, this is about system change, and it's also about cultural change, because I think, we need to get everyone to see health as their business. And of course, what we're saying, and going to the data at the heart of the data sort of piece, and if we go on to the next slide, is this is all about and realizes and recognizes that people need to share their data, and we need to be empowered to do so via better systems and governance and to facilitate wider data sharing across the ecosystem. So we need new models. We need to ensure the value of our data is fairly distributed and delivers a social good. So this whole concept of data as a social good, delivering a public good, is something that we're very focused on in the Open Life Data Framework. And we want to help the pioneers and the innovators develop new ways to grow their businesses, and make money responsibly, while helping our general public and citizens to keep healthy and well, and obviously help them when they're sick in the healthcare system. So ideas that I know have been talked a lot about in this community, like data donation, data philanthropy, to drive up research, for example, and research to prevent risks of diseases, all the things that are in the health and care data strategy. These all rely on trust. And so at the heart of everything is this notion around trust. So again, it goes back to the debate that we're having with the GDPR debate. So I think we've had a few pointers, I think, in the health and care data strategy around this. And, there's some interesting pointers like, we want additional data collected by citizens to improve their health and well-being, things like sleep data, food data, exercise, etc., genome data, to bring our citizens closer to their data. So I think this is all about engaging citizens and why this is important, how data and sharing data can be used responsibly for themselves, but also for the wider good of society. So if we go on to the next slide, and at the heart of this is public trust and, data integration, reuse of data at scale. They can create significant value for everybody, contributors, data reusers, etc. But it does need a high degree of trust. So Now, in the data strategy, it does point an interesting signal to parading an environment around openness, transparency, all these things that I think all of us, here today want to see happen. But the devil is always in the detail, and it's about the implementation. And I think also communication with all stakeholders, including the public. So I had a look at, and you may have heard, the National Data Guardian, they published an interesting report a couple of months ago now, putting good into practice, and this, about this whole public dialogue about data. And, and some of the key findings were around, yes, the public can certainly see how improved health outcomes, reduced health inequality, independent living are some of the main benefits, but less understood are about the benefits that might come from data use beyond those goals. The development of new treatments and technologies, improved efficiency of services. So, and of course, an even more recent report by the NIHR on citizen views on data sharing in the pandemic, they looked at 3 different data sharing models, the COVID-19 data store, summary care record, and also the Open Safely platform, which many of you, and I know Jess Morley has been on this show before. And actually what came tops in terms of public trust is this concept around Open Safely, sort of this trusted research environment concept. So I think all those sort of concepts are really important that the general public understand. So how and what do we need to do now? And so some of the work, and and it seems that clearly there needs to be a much wider debate, a much more bigger engagement with the general public about all these sorts of issues in a much more proactive way, and so that we can also be on the front foot with the media, because they have a huge role to play in sort of this debate as well. So what can we do now? So I had a look at Dr. Bhatti's open letter that was shared, I think, earlier this month, as in anticipation of the data strategy, and I think absolutely some of those recommendations, and again, I'd be really interested to hear the views of the group here. The Department of Health should pay for every GP patient to be written to really lay this the principles of what this data sharing is all about, and what choices they've got. In terms of, and sort of data linkages and all these sorts of things. We need to communicate concepts like trusted research environments, because that seems to be where it's obviously all heading, the positive use cases, not just the scare stories. So these are all the sorts of things that we're looking at in the Open Life Data Framework that we're developing now, which will be published in September. And I think also involving key organizations, which indeed are already involved in the debate, the Wellcome Trust, the Excellent Understanding Patient Data Program, the HDR UK, which are championing this trusted data stewardship, Health Watch, programs like ARC Manchester. These are all key groups, potentially the Health Education England with their information, digital and health literacy sort of work. So these are all groups, but critically, we need to educate government, the general public, obviously business, and just, citizens on all, what does this mean? And critically, the media. So I guess what I'd like to do is just sort of open up this discussion. I see this is a much broader issue around why data is important, how the public need to engage, what will it bring in terms of benefits to themselves, but to wider society, and this new way of seeing data within new models, that will champion this idea of data as a public good while stimulating the SME sector and all the things that we also want to see. So my final word is really how we can potentially involve this community in some of the consultation work that we're going to be doing over the summer with some of the ideas around the governance mechanisms and the framework that we will be publishing to kind of set the stage for how we can create this open innovation platform, that will deliver significant, significant benefits to society around this goal of 5 extra years of healthy life expectancy. So I'm really interested, how we can work with the public, all these organizations, the media, to really, look at this issue of public trust, because it's absolutely fundamental to everything, because without that, we've got nothing. So local models, civic data cooperatives, all these sorts of things we're looking at, really interested in some feedback. So I'll stop there.
Stephen. That's brilliant. Thank you very much. We'll keep rattling on. We're very lucky to have another GP who's also a CCIO as well. So we'll go straight in. Osman, I think you've got a couple of slides you want to share as well. Feel free to take the screen.
Yep, thank you. So I'll just share my slide. So by way of introduction, Osman Bhatti, GP in East London and CCIO for North East London CCG, which is a group of 7 CCGs that recently merged. So yeah, so some of this is going to just enhance what has already been said, really. But I'm just going to go over some of the issues that I feel as a GP. So GPs have historically held data. Patients give information to GPs as data controllers to put into their record, and this is done on trust. And anything that breaks this trust is ultimately going to be detrimental to not only the patient but also the doctor and wider society as well. So that trust has got to be maintained. And we've talked about direct care. Direct care we don't have an issue with. We always share data. So when a patient of mine goes to the hospital, then data is transferred. And similarly, when they come back, data is transferred. And that is something we do not have any contention with at all. The issue is all around planning and research. And of course, we're not concerned about planning and research. Actually, it's a good thing, and this is something we're also doing locally, but it's how it's being done and upholding the security and, more importantly, the confidentiality, which is the issue here. So what is it the NHS want to do? They want to, through NHS Digital, want to look at all the coded information, and this is all through accountability through the Health Secretary, and even the new Health Secretary, and basically through legal direction want to take this and openly have said they want to combine this with other data sources to build a data warehouse. Fine, that's what they want to do, but they did a legal direction published on the 12th of May, and then initially just said within 6 weeks we want all of this information, and that's what was challenged, and the postponement was till the 1st of September as it currently stood. So what is the real issue that we've got? So I think the issue is that NHS Digital want to take direct data from the GP record without discussion really with anybody, because they haven't really discussed it with anyone, and they want to then share it with other sources, and they want to go and share it with other sources. And the question is, we don't know who they're going to share it with, what they're going to do, what they're going to do with the data. And I think if we look at the history of what's happened with data, we've got organizations such as Cambridge Analytica, Palantir, Google DeepMind, and all the rest of it. And I think that's the issue. We do not have any confidence in how this is being run. And we need some kind of openness and transparency, and something called a data protection impact assessment would be useful. But again, we're yet to see that also. And talking about anonymization, we all know about identifiable information. We use that quite often. People who go into trials get consent, and that's an opt-in process, and that's absolutely fine. People choose to do that. On the other side of the scale, it's anonymized. You can't identify who they are, but you can possibly count, for example, count how many patients in your practice or in your area have high blood pressure and diabetes, for example. You don't need to know their personal details. But NHS Digital want to do this in between thing called pseudonymization, where they take the identifiable information, apply a pseudonym, and they will hold the key to unlock that pseudonym. And again, not knowing how, when, and the transparency of that is an issue. So this is where things like a trusted research environment, a TRE, has been talked about. Do exist, not often used probably because they're trusted. And what we really need to do is look at that as an organization where we have data that leaves the GP practice under the knowledge of the data controllers, and then that defines how the data is going to be used, and then it's passed on to whoever. So for example, NHS Digital can then go through that and then go on and share it. And there is constant transparency here, and that's the key to this. And the way to effectively block this, or to for patients to opt out, it's always been really confusing. And I think this is also the issue that we've got, that there is no easy way of doing it. There is a type 1 opt-out where we block the information going to NHS Digital in the first place, and that's a type 1 opt-out. And then there's a national opt-out, which allows the data to flow into NHS Digital, but then NHS Digital hold the key to block it to flow elsewhere. But if we look at historical requests from that, and there's some really good work done by organizations like medConfidential who've looked at this, and you can see that, for example, 80% of national opt-outs have not been honoured by NHS Digital. So that is, again, quite concerning. And I think fundamentally it's down to trust, and until that trust is there, this is what we're advising our patients to do, is to register a type 1 opt-out. Thank you.
Fantastic. Thanks, Osman. Okay, we're okay for time. So Phil, over to you. Thanks for joining.
I'm Phil Goose from medConfidential. And as it's come up in the chat, I'll just sort of make things clear from the start. medConfidential seeks to ensure that every use of patients' data is consensual, safe, and transparent, and that each of those things has meaning. We see no conflict between good research, good ethics, and good medical care. But everything that the government has done since we started, which is a year after the last Health and Social Care Act in 2012, has basically screwed it up. And some of the players have used open as a way to try to drive their own agendas forward. So I would again, as I've done many times over the last decade, ask the open community to be really clear about what it is they are and what it is they are defending and what it is they are doing. Let's be very clear, patient data is not open data. As Marcus said right at the very beginning, open data is aggregate, anonymous data. And if open starts to try to redefine itself so that it can include personal data, and health data is special category personal data, then we have a problem, a real problem. Okay? Now, what limits does that put on what we can do? Well, there are many things that you can do with the statistical publications which the NHS, NHS Digital, NHS England, and everyone else put out. Yeah, if you're doing stuff at area levels, you're not dealing with individuals, there's many things that we can do with that data, and we can also monitor, improve services, all sorts of things like that. However, if what you're trying to do is, as Tina seemed to be describing, is join across data sets and data sources, doing what is called linkage, then almost by definition, what you are doing is handling some sort of identifiable data. For if you cannot reliably link one person's data in one data set to that person's data in another data set, then whatever you're researching or analyzing probably isn't valid. And it is that process of linkage that defines what is identifiable. It's not, am I seeing someone's name or address or NHS number? It's not that trivial. Yeah? Are you able to actually spot an individual and their related history in one data set and link it to another? So if we're clear about that, then we actually have to talk about what can we do? Well, of course, we can put controls around these things. And Osman very elegantly, I thought, described the sort of direction in which we're going. Some great metaphors and good diagrams. But ultimately, and Tina mentioned it too, trusted research environments, what's called a 5 safes safe setting, are places in which safe people, i.e. known, approved, accredited, properly trained people, working on safe projects, which again have research ethics committee approval. They've been assessed for what they're actually trying to do, what their outputs are. Go to a safe setting, a highly secure environment, that could be physically that they go to, or virtually, because we can handle a lot of this stuff through encryption and security measures nowadays, and use what is still inside that safe setting, safe data. Yeah, so we still don't make it like fully identifiable with NHS numbers all over the place. We still use things like pseudonyms to conceal the most obvious identifiers. And then the most critical part is that the information that comes out, the outputs, are safe as well. And those are checked to see if they are statistically non-disclosive. So it's quite possible that some of the outputs of a 5 safe setting would be publishable, and there would therefore be open data. They would be things that we could all make use of. Yeah, we shouldn't be just allowing one researcher or one company come in, do all this stuff and bring something out, and if it's actually statistics, that everyone else doesn't get to see it as well. Yeah. Similarly, if what's coming out are insights or intellectual property based on the public's health data, then it makes sense to assess not just the disclosiveness of that data at the point of exit, but also its value. And this is something we haven't really got into. We haven't really sort of, knuckled down on yet. There's been some work over the last few years about what is the value of NHS data, and frankly, most of it's completely facile. Yeah? Trying to put a number on the price or a price point on data is frankly futile. Data gains value in its use. Yeah? And so what we need to be doing is finding ways to be able to, not knowing necessarily what the ultimate value, commercial value of something may be, to form much more sort of probably complex, but also reasonable contracts about how some of that value comes back to the public services and ultimately helps build our capacity to do more and better research. So I think the thing about public trust is there have been too many people trying to rush around, get all of the sort of the good stuff, not talk about the risks and the downsides, and just relentlessly sort of sell the benefits without acknowledging that there are two major factors which change people's attitude towards this. The first of those is, and this is going back 10, 15 years in the polling. It's pretty consistent. I'm talking about MRC, Welcome, understanding patient data, various polls and studies and surveys all show that while a majority of people are generally happy for their data to be used for research purposes, that majority diminishes. In fact, becomes a minority if you do not seek their permission and if it is seen that commercial interests, especially profit-seeking commercial interests, are involved. And these are not things that are going to shift. These are not things you're going to be able to fix by marketing, by another communications program or what have you. This is something we have to tackle with education, with actually engaging people in what their data is and how it is being used. So the thing I'll wrap up on is what medConfidential means by transparent. We've covered consent, we've covered safe, that's the obvious stuff. Transparent to us is something akin to your mobile phone statement or your bank statement. Yeah? The data that's being processed starts out personal data. It may be pseudonymized, but basically we know whose it is. And therefore it should be possible in any and all analytic environments making use of this to be able to report back who has used your data and for what. Yeah? That can be an on-demand thing. You log in, NHS login, maybe even get it in the app, and you'll be able to see how your data has been used. What this does over time, I believe, will engage people in understanding the richness of what actually does happen in planning and research. You can also add in really helpful things like getting more information. We call patient recorded outcome measures. You could essentially have 100% prompts for anything that's happened to a person in the NHS if they've got a way to talk back directly to you through this channel. We could deal with things like cybersecurity incidents. If there is a breach, those people who've been affected can be informed and told what's going on, and those who haven't been affected can be definitively told that they haven't been affected. Something very new and actually probably a lot more helpful than what goes on in the media, where you see a headline, there's been a breach, and everyone worries. We can also see how our data has been used for direct care. And I thought Marcus made a very important point of disambiguating direct care and research and planning. Yeah, but it is a fact that our information is obviously looked at by care teams and people around the NHS. And if you were able to see who had accessed, for example, your summary care record, and if it turned out that was in a place you'd never been in the country, then you might have questions, and that would be worth following up. So we should be making much more effort on audit, if you like, at the technical level, on governance, if you like, at overarching looking at this, but also involving patients in seeing how their data has been used. Yeah? Not everyone will want to do this. That's fine. Most people just want to be able to trust things. But if those people who have concerns can see the evidence, then so long as we don't screw things up, I think we can get to a much better place.
Thank you, Phil. It's fantastic. I think this is one of the best sessions we've run. So I'm very grateful for you all coming along. We've got a few questions. Tom, do you want to ask yours? And then I've got one for Marcus. Tom King.
Okay. So I realised I'm terribly keen, and I've referred to the life sciences vision, which was published this week, which I'm guessing actually not. Other people haven't seen this, but that describes a review of all the access to data for research purposes, because there are all these, there's CAG, there's iGuard, there are other bits and pieces. I wondered what you thought that was going to lead to, and perhaps that is something Phil has seen. But I'm quite concerned that we're saying there'll be more access to research, and everybody I know complains about the current access process being really slow, and it's not the technical side, it's about the governance process. And of course, if you take longer, there's issues there, and I just wondered what people thought about that.
Okay.
Come back
Yeah,
on.
Marcus, do you want to come in on that?
I think the protections around that data are there for a good reason. So CAG and iGuard and the DARS process and all that kind of stuff is a hard-won set of protections that we've put in place to make sure that that data is appropriately protected. And I think that while I think reviewing the legislation and reviewing the regulation around data, and in particular deregulating access to the data, does not necessarily solve the problem of it being slow to access that, because there are many steps in the process, and a well-funded and supported iGuard can review a lot of applications and can say yes to lots of applications in a very short time. The reality is that iGuard meet for 2 hours on a Wednesday afternoon or something, or I think it might be Thursday, and they are not particularly well resourced, they're not particularly well supported, so the delays come from elsewhere in the system. So I would just counsel you to be very careful about the assertions that are made. So sometimes the assertion that deregulation would reduce the delay and make it quicker is actually a non sequitur. And actually, I think that's often used, this kind of, because the area is very complex, I think there's a lot of distraction being used by people who are potentially have agendas. I think, NHS Digital, much as I work with close colleagues from NHS Digital, they in themselves have an agenda in this. And you need no more evidence of that than to look at the behavior that they've exhibited around the opt-out process. So they are definitely taking it personally if you want to opt out. Now that to me doesn't appear to suggest that they're impartial in this process. They're not dispassionately saying you may opt in or you may opt out. They're actually expressing some disgust and disappointment for those people who do want to opt out. That tells me that they have an agenda. So a lot of organizations have got agendas. A lot of them will tell you things. And I think just as a group of intelligent people, I would encourage you to really actually follow the logic right through the thread. So we don't necessarily need to deregulate things to make them work better. We can have good quality research and planning done with consent. Even we could have full consent. There's no reason why that couldn't happen. It's just it's been dismissed out of hand because somebody doesn't want to do it. So
exactly. Just to add to what you're saying, Marcus, and you got to it essentially. Yeah. Do not assume that the reason why something took a long time to get is because someone was resisting it. Most of the applications are crap when they start. Yeah, new applicants ask for a whole bunch of stuff and there's just no legitimate basis for it, and they get annoyed that they don't get the data because they have to go through a bunch of process because they haven't actually demonstrated, as you need to do, that what data they need for what they want to do. That's the job of a legitimate research program. If you say give us everything because we want to do some good stuff, yeah, you will get laughed out of court, and rightly so. So yeah, let's please not put blame. I think, as you said, everyone has agendas. Everyone has agendas here. But I don't buy this, oh, well, you know, we need to remove governance and everything will just get quicker and cleaner. It won't. Everyone is trying to inject their own, you know, interests in and around these processes. What we need to arrive at is one that is robust and that works for everything. As someone said in the questions, Lisa, I think, said, you know, we're not just talking about research. We are talking about planning. We're talking about public health uses. We are talking about service improvement. We are talking about policy making in some instances. Yeah. So we have to get a system that works, you know, universally, yeah, that works as efficiently as possible, but is actually effective at delivering one key thing that we keep on coming back to, which is trust, not data. Trust.
Thanks, Phil. Alex, you've got a question.
Yeah, thanks, Mark. Hi, everyone. I think it's been a really good discussion. I haven't disagreed with a lot of what's said. I was just going to make the point that I think in a lot of the discussions about this, there's been a real kind of polarization and an assumption that sharing this type of data in the safe way everyone's been described is a bad thing if it's a private or a for-profit company, and it's a good thing if it's a research organization, academia, or a not-for-profit. And I did some work. Sadly, Dame Fiona Caldecott passed away this year. She was a lovely lady, as everyone knows. I did some work for her on Caldecott 2, and I think we reached a good form of language in there, which was something like other reputable organisations. And you know, I've worked with you, Mark, for profits, which I think had a very strong public sector objective and wanted to do the right thing. And there are unfortunately some charities and not-for-profits who, you know, are heavily regulated, who have done some bad things and intend to do some bad things. And indeed, some charities, and good luck to them, even though they're a not-for-profit, make a lot of surplus and divest that in salaries, and, you know, fantastic, good luck to them, but they're not necessarily for God good because they're a not-for-profit or a B Corp or anything else. And I actually think this group's been very responsible in their language and what Marcus and Osman and Tina and Phil were saying. But I just think it's worth calling out that it's about data, getting this data to organisations that want to do the right thing, and we shouldn't be hung up about whether they're constituted as a not-for-profit or a for-profit. It's testing that and testing the shareholders and testing the leadership, rather than saying, well, you're a for-profit, therefore you're bad and you can't have the data.
Okay, Paul, do you want to come in there? Thanks, Alex.
Yeah, and I think so. I'm not a health professional. I don't live in this world every day, but it's fascinating to me how things do play out, and the public good, private bad language. You do find that more in health, and it's quite interesting. So I'm just going to. We've mentioned Open Safely in the chat, and I think everyone has, and I think that, you know, it's a really great example. And Ben Goldberg is a friend of ODI Leeds and Beautiful Info and Open Data Saves Lives, and their team, and Jess has helped. I'm going to ask Chris Bates of TPP, who's just become a sponsor of Open Data Saves Lives. Could you just share a little bit about how you see the GP data world linking and crashing into Open Safely against my impatience of wanting to do innovation quickly and fast and doing good things quickly and fast and not getting caught up in the dark matter of governance? Because even though governance is really important, you should only need to do it once. And if we do it once for one subject and it gets signed off, that should be it. You know, we've agreed it, it's been shared, that everyone's happy with that, we iterate, we improve. It shouldn't be that every single transaction has to go through the same governance process every single time. Not that it does, but sometimes you do feel as if that does happen, in that there's a lot of cognitive load in everyone making the same decisions constantly. So Chris, if you just give us a couple of minutes on how you, because obviously a private company, and you've been taking on a bit of a journey with Open Safely as well, haven't you?
Yeah. I mean, Open Safely has been extraordinarily interesting. I mean, to your governance point, that kind of is what we spent the first 6 to 8 weeks at the start of the pandemic doing in parallel to the technical stuff, was a hell of a lot of governance work with NHSE. I mean, Open Safely remains an NHSE asset, and all, you know, we were talking earlier about what projects can run, etc. It's all controlled by NHSE in the processes for running those. I think so that governance part, I think you're absolutely right, Paul. I think getting that in place early on was fantastic. What Open Safely has been great for, and earlier on in the chat was kind of that Mark was putting on about the balance of how do we balance that sort of risk of re-identification versus, as you're saying, the ability to do analyses on very powerful data. And I think what the approach has enabled with Ben and the team is that we have been able to do those powerful analyses without, you know, taking some of the really sort of powerful event level data we've got in primary care in the UK, but putting it away where there is that that public trust. And I think, as somebody said, Jess Morley in the citizen juries last week, Open Safely comes out very, very positively there, because people like the mechanism of you can see, you know, and I'll put it in the chat now. You can see exactly what's running on Open Safely at any given time. So if you go to jobs.opensafely.org, you can see now on that website exactly what's been executing against that database. What jobs ran last night? I don't think anything's run this morning. You can follow that to see the code that was executing, all the outputs of that, and you can contribute to it. So there is, you know, complete transparency at the same time as that powerful analysis and that governance structure in place. So I'm really hopeful that that's a model that people can build on. And I think it's good to see people talking more seriously about TREs. I think it's been really interesting to build one specifically for EHR data, but it's not just a kind of out of the box one that has enabled us to develop, but enabled us to control in this environment. And yeah, long may it continue. So I think, you know, to Phil's point earlier, you know, patient data is not open data and never will be. But approaches like this do mean we can do things in an open environment, retain that power, but retain, most importantly, public trust.
Thanks, Chris.
Thanks, Chris. That's really helpful. I would point people, if they missed it, to Stuart's description of why he was comfortable with Open Safely, which might link to your point, Tina. So I'm going to ask you to come in, but I think the way Stuart articulates it is possibly some of the point that Tina's going to make, is it's all about how you talk to people about how their data is being used. And I think that's a really nice articulation of it, Stuart. Thank you. Tina.
Yeah, sorry, not on mute. Yeah, I just wanted to pick up. I mean, I think I was really pleased that, you know, this whole notion that, you know, private sector and business is bad. I think, you know, in the end, you know, all of this is about the transparency. Yes, you know, informed consent. You know, these are at the heart of whatever governance mechanism is put in place. They have to address. I just put in the chat. I mean, what Phil was describing is very much how the Estonian government do it in terms of their e-citizen initiative, where the citizen chooses and there's a mechanism by which they decide who they share their data with, whether it's public sector or private sector. So that's all built in this system that they have. And just a word on the private sector. I mean, I think what's interesting is that in the end, it's about harnessing data sets for what purpose and to deliver on what public good, which is the key thing that the public has to understand. And some of the work that I'm doing with the business community, and of course there is a big shift, you know, in terms of responsible investing. We're seeing that in climate change. What we want to see is that same discipline and that mentality to be entering into the health space, so that there's more investment going into socially responsible investment into health as an asset. And I think if we have a data-driven approach, which is built in the whole way that we can create this structure in terms of data sharing, how we measure the value of that data, how we deliver on the public good for these big challenges that we face as a society, it just means we can do something in a way that's much more powerful. But at the heart, and this was obviously where I closed my presentation, it is about the trust. How do we do that? So I think some of the models, which I had mentioned earlier, like civic data cooperatives that Ian is doing, and this is all about engaging people within a local diameter of trust, which, you know, in populations the size usually of about 5 million, which incidentally is the same size as the Estonian population, because you can then, you know, really sort of do things in a way that's much more sort of linked in with local priorities, and that's of course where some of the stuff that government talked about leveling up are really powerful. So I just think we need to really think differently about trust what it means for public sector and private sector as a system change thing around just really seeing things differently. And so I just wanted to make those points really.
Thank you. Stuart.
Hi, yeah, I'm from ODI in Leeds. I just wanted to clarify, when I was bringing up open safety, I was pointing out why I have so much more trust for them than the GPDPR situation, because they've been very clear from the beginning about lots of things. It's not that I necessarily think they're entirely trustworthy, it's just that they've been a lot more clear about what they won't do with things, which I'm very much in favor of open data, that's what I do all the time, but I'm also clear about limitations of things. And if you don't show any limitations or just say everything's good, the messaging has all been, this is all data for good, there's nothing to see here, stop worrying about it. Rather than acknowledging the actual concerns about privacy and things, I feel like Open Safely had done a much better job around that. So it's not just about public education and telling us that we just need to understand it better, that we just don't understand open data. And we need to get that. It's more about maybe the government side of it being clear about what they will and won't do with data as well. Sorry.
Thanks, Stuart. Marcus, last word, and then we better wrap up because we've got a minute.
Just a couple of things about Open Safely. I think Phil's very good to point out that the legal basis for Open Safely is really under the COPI regulations. It's control of patient infection. It's only valid through the pandemic. So I would like to see further work on Open Safely to make that applicable to a kind of non-pandemic situation. I think there's work that needs to be done, but I still think that they're way ahead because of the way they've gone about it. And actually, another aspect to allude to, which is vital, is that Open Safely addresses the data in situ, where it already is, in this GP systems suppliers' databases. And that's a very different proposition from extracting all that data and sending it to NHS Digital, which is the GP data for planning and research model. Now, they have, again, organizations with agendas seem to use a lot of language that suggests that what people are really worried about is the onward dissemination from NHS Digital. But what if your worry is NHS Digital having the data in the first place, bearing in mind that NHS Digital are funded by NHS England, who are funded by the Department of Health and Social Care. So they are the government, they're just two quangos away from the government. So it's really vital to remember that, there are ways of analysing this data in situ. And the other thing about Open Safely, which I think is a benefit for the open data community, is that the approach they've taken throughout has been that the analyses and the tools around and analysing that data are always public. So it means that researchers can use other people's work much more readily to build on existing work. So you're not having to start from scratch with research. You can actually take a research project that kind of almost does what you need it to do, modify the code slightly and submit that for approval, knowing that similar code has already been approved. It absolutely transforms the analytics space by just reducing the friction and making it way easier to use. So I think they've done such a great job. All we need to do is help them to solve the last few problems that medConfidential have pointed out, and which I support. Those things need to be sorted out, and really I would very much like to see an Open Safely.
On that note, it's 1 o'clock, I'm conscious, and usually when you run something like this, as it gets to 12:59, the numbers on the call just drop like a stone, but everyone's still on. So everyone is late for their next call because this has been such a brilliant session. I mean, it's been fantastic. Can I just thank Ali for putting it together? What a brilliant group of speakers. We will write this up, we will share it all. I'm hoping, if we may, we might come back round having created this network. I think Paul's point about open innovation is actually much more important than open data. Open data has kind of been around for 30, 40, it's not that new or interesting in some ways, but this is much more interesting. So if we may, we will keep in touch and we will circle back and we will write it up and we will keep in touch. So thanks for Ali for putting this together, and we will all speak soon. Thank you so much. Have a good lunch if you've got time. Take care.
Thanks
Bye-bye.
so much.
Thanks, everyone.